Okay. So, good afternoon, good evening, everyone, whichever parts of the world you're in. Um, Welcome back. I have had a small little break on leave, but Lydia and colleague Ava have very ably maintained the program, and I hope it's been useful. I know that there's been pretty high attendance to some of the talks. So, apologise, I'm away again, but I wanted to maintain the continuity. So, I'm not able to show some heme slides today, but I can do better than that. And I know this is a recording, but I am going to be around at the end for Q&A for an extended period of time. I actually do for quite a bit afterwards. And this is actually quite an important topic. So Dr. Ayoma Attygalle at the Pathological Society Winter School gave an excellent talk on Hodgkin lymphoma and its mimics. And this is a really difficult area of pathology. Hodgkin lymphoma, when it's classical, is really easy to identify, but particularly in needle core biopsies and some atypical cases, the distinction between reactive nodes and some T-cell lymphoma.
Did your internet go, Richard?
In lymphoma is Hodgkin versus reactive. So without one final thing is to say thank you very much to Lydia for all the support she's given to the program over the last few months, well, several months, and to Diagnexia. She will be Ava, her colleague, will be taking over from next week. Lydia will still be in the background for a couple of weeks, but I think on this occasion, which is still front of house, I'd like to formally thank her for all her input on my behalf and your behalf as well. So without further ado, I will pass over back to Lydia and she will start the recording, but I will be here and following along with it as well. So thank you very much.
Perfect. Thank you, Richard.
Thank you.
I will just press play now. If someone could give a thumbs up or raise a hand just to make sure that the sound is working on your end, and then we'll get going.
Here, okay, so without further ado, we'll start the slide seminar, I think. So just minimize this, sorry. So Hodgkin lymphoma actually encompasses two distinct entities. Historically, they were grouped together, and therefore, hence that they both have the term Hodgkin in their name. But when we refer to Hodgkin lymphoma, most of us associate it with the classic Hodgkin lymphoma, which accounts for 90% of these cases. However, around 10% are accounted for by nodular lymphocyte predominant Hodgkin lymphoma, which we now, and for years now, we've known to be a completely different disease entity. So much so, the WHO does recognize this as a different disease entity, but still has retained the name. However, the alternate classification, which came out at the same time as the 5th edition of the WHO, the International Consensus Classification, recognizing this, has changed the name to nodular lymphocyte predominant B-cell lymphoma, because these tumors actually behave more like low-grade B-cell lymphomas rather than Hodgkin. So this is very important to get right. They're two distinct clinical pathological entities. So what do these have in common? They are both nodal lymphomas or node-based disease. Both are lymphomas that tend to affect the young, and they're both characterized by large atypical mononuclear, multilobate, or multinucleate cells surrounded by a variable mixture of non-neoplastic inflammatory cells. And the neoplastic cells are often ringed by T cells forming rosettes. But if you compare these two, classic Hodgkin lymphoma has a bimodal distribution in terms of presentation. So that occurs in the young between 15 and 35, and there's a second peak later in life. Nod-lymphocyte predominant Hodgkin lymphoma does occur between the 30 to 50-year age group, but it is also common in children. EBV may play a role in classic Hodgkin lymphoma, but EBV plays virtually no role in NLPHL, is that what I'm going to refer to it as from now on. Both are germinal center origin. However, in classic Hodgkin lymphoma, the B-cell markers are absent, partial and weak. And other than for PAX5, which is expressed weakly, the other B-cell markers are typically not expressed. Some CD20 can be focally weakly expressed, but otherwise not. On the other hand, NLPHL, the pan-B cell markers are all expressed. And a feature of classic Hodgkin lymphoma is that immunoglobulin transcription is inactive, and we'll see how this is useful diagnostically as well, whereas in NLPHL, immunoglobulin is synthesized. With modern treatment, majority of classic Hodgkin lymphomas are curable. In NLPHL, it behaves like a low-grade B-cell lymphoma. It's indolent, which has relapses, but rarely it can be fatal. Now, clinical history is also quite important sometimes because of the histological mimics that occur. If you take classic Hodgkin lymphoma, it's a painless lymph node mass. It's not typically rapidly enlarging like you'll get in an aggressive large B-cell lymphoma, for instance. And also, something that is always the case is that it involves contiguous nodal groups. So they occur in a chain. And cervical and axillary nodes are often affected. Inguinal nodes may be involved, but they have to be part of a chain. You don't get isolated groin node involvement. Mediastinal involvement is common, and if it involves the abdomen, it's axial nodes that are involved. So it will go on as a chain if it comes from the thorax down to the abdomen. And mesenteric nodes, for instance, would be very rare naturally. On the other hand, in NLPHL, you have isolated lymphadenopathy of long duration, which can be even about maybe years, sometimes several years, and background progressive transformation of germinal centers, which is a reactive condition, which may be seen. It's not uncommon, and remember, this lymphoma is uncommon. So it's an uncommon complication of PTGC, may precede or follow NLPHL. Infrequently, it may occur in the same node or even in the same follicle. I've got a little image here of PTGC, which is an enlarged follicle. And you can see there's an increase in mantle zone type B cells. You can see the IgD, and they sort of encroach into the follicle center. And as a result, you get this moth-eaten follicle center. So if one follicle has both conditions, you can see PTGC here, moth-eaten germinal centers, and NLPHL, you can sometimes see it even in the same follicle. So NLPHL frequently involves cervical, axillary, less frequently femoral and inguinal. Mediastinal involvement is rare, and mesenteric lymph nodes, on the other hand, may occur. Most classic Hodgkin lymphomas are low stage, but in advanced stage disease, you can have distribution like spleen, and less commonly liver, bone marrow will be involved. NLPHL, most are low stage, but about 20% of cases, there can be advanced stage disease. Now, morphologically, if you look at these two, so classic Hodgkin lymphoma is characterized by this Reed-Sternberg cell or the mononuclear Hodgkin cell. You have abundant cytoplasm. There are these large nuclei. This is a textbook case. Textbook as in this is a case of mine, but it's a textbook appearance. You can see there are these central eosinophilic macronucleoli with this characteristic perinucleolar clearing. And you can see that here as well. Sometimes, especially in the nodular sclerosis subtype, you see a lacune, and you can get sometimes these mummified cells, which are also characteristic. Background, you have to see, which is either a mixed inflammatory or a lymphocyte-rich background with or without histiocytes. And in NLPHL, typically you have the popcorn cell or the LP cell as we refer to it now. It has abundant cytoplasm. It has these multilobate nuclei. The nuclei are much smaller, and you have this sort of almost bubbly chromatin, and that's why the name popcorn, because the nucleus looks a bit like a popcorn. Background lymphocytes, they're small lymphocytes. I'll come to that in a minute in terms of what the composition is. You have B cells as well, small B cells, but the rosettes are formed by strongly PD-1 positive T follicular helper cells, whereas in classic Hodgkin lymphoma, the T cells that form the rosettes lack this strong TFH marker expression or PD-1 positivity, so that's also a feature. And sometimes in NLPHL, you can get a large number of histiocytes mixed with the background small lymphocytes. Classic Hodgkin lymphoma, there are the 4 subtypes which is still recognized, the nodular sclerosis subtype, which is more common in resource-rich areas, and 80% of these show mediastinal involvement. It is a lymphocyte-rich subtype that enters into the differential diagnosis with nodular lymphocyte-predominant Hodgkin lymphoma. We'll see that later. And mixed cellularity is more common in developing countries in HIV patients, and these are frequently EBV positive. In Western populations, it's uncommon, so much so that if you come across this subtype, you have to always exclude other differential diagnosis, such as T-cell lymphoma, for instance, the angioimmunoblastic type of the nodal TFH lymphoma that can have this similar type of background and can be a pitfalling diagnosis. The lymphocyte depleted is often a misdiagnosis because it mimics other non-Hodgkin B-cell lymphomas, and it's invariably a large B-cell lymphoma or T-cell lymphoma that is misdiagnosed as classic Hodgkin lymphoma. Immunophenotypically, these two entities are completely different. So if you take classic Hodgkin lymphoma, it's strongly and uniformly CD30 positive, and CD15 may be positive. Whereas in NLPHL, CD30 and CD15 are typically negative. Now, the B-cell markers, as I said, CD20 can be focally weakly expressed in about 30%, but other markers such as CD79A and CD19 and other CD22, etc., they are all negative. PAX5 is, you look for it because that is the only marker that is expressed, and that's useful in telling us this is actually a B cell lineage. So, but CD45 will be negative and EBV may be positive. Whereas in NLPHL, in addition to 30 and 15 being negative, the B cell markers are strongly expressed and CD45 is positive and EBV is negative. Now, immunoglobulin transcription is very different in these two. So in classic Hodgkin lymphoma, immunoglobulin transcription is crippled. So immunoglobulins are not synthesized. So therefore, the J chain, the joining chain is negative. Immunoglobulin heavy chains, light chains will not be expressed. If you see it, it will be a non-specific uptake. And the transcription factors associated with immunoglobulin transcription are also not expressed. So OCT2 should typically be negative and BOB1. Having said this, you might find one of the two markers present, but never both. On the other hand, in NLPHL, the J chain will be positive and immunoglobulins will be expressed. You'll see light chain restriction because it's a clonal proliferation, and OCT2 and BOB1 will be expressed. And OCT2 is a beautiful marker in this disease, and if you use this, you'll identify not just the large cells, you'll see the rings around them. I'll show it to you in a little while. The T cell rings will be negative, and then you'll have the nodular areas with the small B cells also being highlighted. So this is a very useful marker. Now I'll ask you a question and I'm going to answer it because it's not a poll, but if you see Hodgkin-Reed-Sternberg cells in a biopsy, would this equate to classic Hodgkin lymphoma? And the answer is no. The reason for this is in order to make a diagnosis of classic Hodgkin lymphoma, it requires not just HRS type cells, but also an appropriate background, inflammatory background. And sometimes in difficult cases, you might need clinical and radiological findings with or without genetics. And this correlation is very important in order not to make a misdiagnose the case. So although the features are quite typical histologically, the diagnosis of any lymphoma should require an integrated approach. Now, I'll give you some examples of cases that can have HRS-like cells, but is not classic Hodgkin lymphoma. One such example, you can see it's a textbook Reed-Sternberg cell, but this is not classic Hodgkin lymphoma. This is not nodal T follicular helper cell lymphoma, the angioimmunoblastic type. So if you're lucky, you will see these neoplastic cells, that clusters of these pale clear cells and an increase in high endothelial venules. But if you take this case that you can't see the atypical lymphoid cells that clearly, but you're seeing a background which would do sort of for mixed cellularity or even nodular sclerosis, where you're seeing the mixed inflammatory infiltrate. But the rosetting cells are actually not the reactive T cells, but they're neoplastic T cells. So they will be strongly positive for the TFH markers, including PD-1, and many express CD10. So you can see this is aberrant in this context. And so these things give you a clue. You also see this proliferation of FDC. To this extent, you don't see it in classic Hodgkin. But the difficulty is the similarity of this mixed inflammatory background, and you might not always notice these neoplastic cells. And sometimes if you see large cells, your eyes go to that and you don't really look at the background. So that can be a problem. EBV is positive not just in the HRS-like cells in these cases, but also in a range of immunoblasts and other, so the cells will be polymorphic. The cells will have a range of cell sizes that are EBV positive. If you run into difficulty, correlate clinically, and other immunohistochemical markers such as the TFH markers, genetics, clonality, and a mutation profile, all these can help. Another example of a case that is an entity that has HRS-like cells is the reactive infectious mononucleosis. And there is a saying to say that one of the pitfalls of infectious mononucleosis is a biopsy, and if a pathologist then misdiagnoses it. So you can get these HRS-like cells, but the background has this varying sizes of like big plasma cells, almost like plasmablasts, immunoblasts, large plasma cells, and these HRS-like cells, and they will all be EBV positive. So you get this range of sizes, and you can see the CD30 is quite strong. They shouldn't have eosinophils, and CD15 is usually negative. The tonsillar location also should provide you with a clue, because that is not a distribution that you expect in classic Hodgkin lymphoma typically. So that should always alert you. The last entity that I'm going to just very briefly tell you about is this EBV positive mucocutaneous ulcer. Again, the site is quite important, because at this site you don't really expect to find classic Hodgkin lymphoma. But this is an ulcerated lesion, and you see this band-like CD30 positive infiltrate, which is EBV positive. There you can get HRS-like cells, but you get a lot of other cells which look like they're just large lymphoid cells, which are B cells. Now, very briefly, before I go on to the cases, I'll tell you a little bit about the nodular lymphocyte. Predominant Hodgkin lymphoma, this is not something that you have to know in detail. This is just extra in a way, but there are various patterns. So depending on the number of small B cells that you see, the large B cells that you see, and the background T cell population. So the typical patterns are patterns A and B, and they are considered to be of good prognosis. C, D, E, and F are more advanced disease and advanced stage disease and have a higher rate of relapse. And I won't go into this in detail till I go through the cases. And this is an image I got from the WHO Blue Book, which you all can look at. And this gives you these different patterns. And we'll come to a little bit about these later. So in nodular lymphocyte predominant Hodgkin lymphoma, the nodule is formed because of this follicle, which has FDC meshworks, but there are these holes which contain these large cells, and you can see these T cell rosettes. As I said, the OCT2 is a beautiful stain because it highlights these cells. It also shows these negative staining in the rosettes, and you see these background small B cells. So all these three features and the FDC are features that you have to see in nodular lymphocyte predominant Hodgkin lymphoma. So if you look at the nodules of nodular lymphocyte predominant Hodgkin lymphoma, they have these popcorn or LP cells, and the background is composed of small lymphocytes. What about follicular lymphoma? It's also follicular. You see centroblasts. In some ways, NLPHL LP cells are like distorted giant centroblasts with a polylobated. So these are the centroblasts you can see here, and in the background are centrocytes, and they are not reactive mature cells that are around here. You can see they're irregular and cleaved. So there is a difference there. So first case is a 23-year-old female with left cervical lymphadenopathy, but you can see that there's left cervical axillary mediastinal retroperitoneal. You can see it's now going in a chain. Pelvic, so it's going, in a chain. So pelvic is okay because it's coming right as a contiguous chain of nodes. Liver and spleen also involved with focal lesions. So this is extensive disease, and this is what we see. And this is what you would have seen also in the scanned slide. So this is, you can see that there is capsular sclerosis, and there's you can see this sclerosing bands traversing the lymph node, separating into cellular nodules. And here again, you're seeing the same thing. If you look at these nodular areas, there are almost sheet-like infiltrates of large cells, and there's a background of inflammatory cells, which include eosinophils, and we'll see some more of this. We'll see some plasma cells, etc. as well. So you can see more of this same thing, and you're seeing here it's almost quite cohesive. You're seeing these infiltrates, but you can see that these have these nucleoli, which are cherry red here. And some of them you can see here. We'll see a little bit more here. And here you're seeing more like the cherry red nucleoli here. Here again with the perinucleolar clearing. And the background you're seeing in this field, you're seeing mostly small lymphocytes and plasma cells. We saw some eosinophils before. And here again, you're seeing the eosinophils. So it's a mixed inflammatory background with these. And in some areas, you're not seeing the sheets anymore. You're seeing them as individual cells. So you're seeing a variety of, your concentrations of these atypical cells. So here, this is more focusing on the background, and you can see background is a mixed inflammatory infiltrate. On the CD30, in the areas that are sheet-like, they're strong and diffusely positive, and in the other areas, they are more sparse, but still they're in clusters. So if you see sheet-like infiltrates with strong and diffuse CD30 positivity in these atypical cells, what do you think? So one possibility is anaplastic large cell lymphoma, ALK positive, anaplastic large cell lymphoma, ALK negative, and of course, classic Hodgkin lymphoma, nodular sclerosis subtype with a syncytial growth pattern. Primary mediastinal large B-cell lymphoma, but primary mediastinal large B-cell lymphoma, although it's in the mediastinum and it can affect the supraclavicular, it's not a nodal-based disease outside of this, so it tends to spread extranodally. And embryonal carcinoma, just if you see sheet-like infiltrates, might be a possibility. So if you take anaplastic large cell lymphoma on your left and our case on the right, you can compare the nuclear features. You might say, well, they look similar, but actually they have multiple basophilic nucleoli. They don't really look the same, and you're not seeing these cherry red nucleoli with the perinucleolar clearing. The CD30 pattern of expression is very similar because you have this membrane staining and the Golgi staining, so that is okay. And our case was CD15 positive as well. So that is an important thing. PAX5 is weakly positive compared to the B cells, small B cells in the background. CD20 is negative. CD79A, CD19 and CD22 are all negative. OCT2 and BOB1 are negative. CD23 is highlighting FT follicular dendritic cell meshworks, but the cells themselves are negative. And CD3 is forming some form of rosettes in these areas where they're separated out. So if you take your differentials, in ALK positive anaplastic large cell lymphoma, ALK will be positive, PAX5 should be negative, and you'll see a range of T cell markers, and including CD43. You may or may not always, sometimes they can be null, but PAX5 will be negative. And anaplastic large cell ALK negative will be similar, but ALK will be negative. So our case is classic Hodgkin lymphoma, as you would have guessed, and primary mediastinal large B cell lymphoma. Just on pathology alone, it will be positive for all pan B cell markers, and CD23 is positive in 60%. So you can exclude that very quickly. And embryonal carcinoma, they are typically A1, A3 positive, PAX5 will be negative, and CD15 will be negative. So further stains, MUM1 is a marker which is quite useful in classic Hodgkin lymphoma. It's not specific at all, but it is sensitive. So if you have a case, and I think it's classic Hodgkin lymphoma, but it's MUM1 negative, I'll think again. P53 is also strongly expected, but there's no underlying mutation. CD45 is difficult to interpret because of the large number of CD45 positive cells in the background, but because this is slightly syncytial, you can appreciate that they are negative. There's another marker which is seen in histiocytes. This is facin, which is positive, and that's kind of useful. But not all labs have it. EBV in this case was negative. So the diagnosis in this case is classic Hodgkin lymphoma nodular sclerosis subtype. And EBV is negative. The next case is a 56-year-old male. There's a prominent lower right cervical lymph node. There's left paratracheal node and an anterior mediastinal prevascular nodes measuring. So they're not that large. Largest is 2 centimeters. But again, it's a chain of nodes. Submitted was the mediastinal lymph node core biopsy. So in this core biopsy, all you're seeing these large cells, and they're these cherry red nucleoli, some perinucleolar clearing, and you're seeing more of these. They're mononuclear for the most part, and you're seeing a background which is rich in lymphocytes. Now, one thing I did tell you that in nodular lymphocyte predominant Hodgkin lymphoma, they tend to be like popcorn, the nuclei. You have these lobulated nuclei with this sort of fluffy kind of chromatin and smaller nucleoli. However, on morphology alone, sometimes classic Hodgkin lymphoma can have cells that resemble the LP cells, and LP cells, NLPHL can sometimes have cells that have central nucleoli. So on morphology alone, it is very difficult to be 100% sure, especially on a core biopsy. So there's a vague nodular architecture. I don't know whether you appreciated that. They're individually scattered large, mostly mononuclear cells with large eosinophilic nucleoli in a background rich in lymphocytes, but there were no eosinophils. So the differential diagnosis would be classic Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. So on the basis of morphology alone, in these core biopsies in a lymphocyte-rich background, you cannot really tell them confidently apart. So that's something at the exam also you should give both options as a differential if you get a lymphocyte-rich background. But immunophenotypically, they are very different. And I'm not going to go through this again. So it's very easy for us, if we use immunohistochemistry, to tell these apart. So now the CD30 is positive in these atypical cells. So that's very clear. You can see this one is binucleate or bilobed, and this one again, you can see many more cells that we appreciated maybe on histology alone. So this tells you now this is not going to be NLPHL. This is also CD15 positive. This is very helpful as well. And you can see the CD3 forming the rosettes around these. Yeah. And PAX5 is weakly positive. That helps us because we know it's a B cell neoplasm, classic Hodgkin lymphoma, but a lot of the B cell markers will be negative. But the other B cell marker, CD20, for instance, is highlighting these background small B cells, and so is the 79A. OCT2, unlike in NLPHL, you can see it's negative and highlighting only the background small B cells. BOB1 is similar, and IgD is what highlights these small B cells in the background. So the presence of these small B cells in the background and the presence of T cells would be common in both entities. However, in NLPHL, those T cells will be strong PD-1 positive cells. So this is the FDC meshwork. So both have underlying FDC meshworks. So this is actually an area where there's a germinal center. And just to say, in classic Hodgkin lymphoma, it's in these, when they're involving a follicle where there's a residual germinal center, it's not moth-eaten, it's like this, eccentrically located round follicle center. And the HRS cells are seen amidst the small lymphocytes in an expanded mantle zone. And here again, you're seeing these holes again, like we saw before in NLPHL. So that doesn't really help us very much. So CD23 is also highlighting small B cells, but also the FDC meshworks. So P53 here is positive. Sorry, just bear with me a second. So P53 is positive, MUM1 is positive. As I said, these are useful markers. FACIN is positive and EBV is negative. So this is classic Hodgkin lymphoma, lymphocyte-rich subtype, EBV negative. Now, I was just wondering, Sindhu, whether anyone has any burning questions that I can take now on these before I move on.
I think we'll leave the questions to the end, if that's okay, Ayoma.
Absolutely fine. Yeah. So these both were, one was classic Hodgkin lymphoma, nodular sclerosis subtype, and this is classic Hodgkin lymphoma, lymphocyte-rich subtype. Okay. This is also EBV negative. Next one is a 7-year-old female, enlarged right cervical lymph node, submitted for histology. So let's have a look at this. This is cervical lymph node. So this cervical lymph node, I apologize for this, this strange pattern of staining that has occurred, but you can see that even at this part, this is a face nodal architecture, a vaguely nodular appearance. And you can see even here that they're clearly small B cells, small lymphocytes seem to be in the majority here, but there are some areas which look a little paler, which suggests that there may be something else going on as well. So looking closer, you're not really that much wiser at this power, but if you go closer, you can see that you're seeing large cells here, and they're atypical. As I said, some of these seem to have cherry red nucleoli. Others have these sort of almost like an enlarged centroblast. And some of them are sort of multilobed, but you're seeing a popcorn type appearance. Another one here, which is bilobed with small nucleolus and a popcorn appearance. Background small lymphocytes. And there you're seeing histiocytes as well. So there are no eosinophils, no plasma cells. And here again, you're seeing more of the same. The nucleoli are smaller than what we saw in the classic Hodgkin lymphoma. But as I said, on morphology alone, sometimes it is difficult to tell these two apart. But we know immunohistochemistry is going to be very helpful. So let's move on. Now look at the CD30. This is something also very important to recognize, that when you look at any immunostains in, I guess it's across the board, but very important in hematopathology, is that you not only look for what is positive, but what is negative. So if your eyes are drawn to the CD30, you might just think they're largest cells, the tumor cells are positive. But actually look around and you will see the actual culprits, which are the really large cells, are negative. So large cells are CD30 negative. Remember that CD30 can be positive in any activated lymphocyte, whether it's B cell or T cell. Now look at the CD20. CD20, you can see the nodular pattern here, and they are highlighting not just the large cells, but the small B cells in the background as well. CD3 is forming these rosette-like structures, and also there's an increase in the follicle itself. CD23 is highlighting these FDC meshworks, and you're seeing these as you're seeing the holes in which these large cells lie. And this is OCT2. OCT2 is a very useful marker. It shows you the nodularity. It also shows the composition of these nodules, that there are small B cells and there are these large cells. And this is really very useful. Even in screening power, you should be able to see this. And if you look at these, you can see the negative cells are obviously the T cells. And if you get good light chains, you can see that if you look at the light chains, you'll say that both are positive. Actually, they are positive, but both are positive in the small B cells. So if you look at the small lymphocytes, they're positive, expressing kappa, and some are expressing lambda. So they're polytypic, not surprising because that's a reactive component. But look at the large cells. The large cells are expressing kappa, but they're negative for lambda. And any weak staining here is non-specific. So this is kappa light chain restricted. So you can see this is expressing immunoglobulin. PD1 is very strong, and it expresses, you can see that it's forming the rosettes as well. So I want to at this point highlight that when you see the strength of PD1, previously we didn't even think about nodal TFH lymphomas entering into the differential. But now that we do PD1 in the nodular lymphocyte predominant Hodgkin lymphoma, there are misdiagnoses. These cases, the clinical history is often very different because this is, remember, this is a young patient where you don't get this nodal TFH lymphoma. But in the older patients, if there's more disseminated disease only, does the differential come into the picture. But morphology alone, if you have no clinical, can confuse you. So remember, the TFH cells are atypical. They can often express CD10. You'll have the FDC meshworks, just like, and you'll see this, they are often EBV positive, these cells, and they range from B immunoblast to HRS-like cells. So these, if you have any problems, of course, you can do clonality and mutational analysis, etc. So this diagnosis is not a lymphocyte predominant Hodgkin lymphoma, and this is fan pattern A/B, which is typical. So fan pattern A and B essentially are nodules rich in small B cells with scattered large cells, and you have these rosettes. So this is the, say, pattern B if it's serpiginous and interconnected nodules, but otherwise, so some of them are serpiginous, some of them are individual, but main thing is they are the typical patterns. So they are not variant, and this has a good outcome. Next one is a 76-year-old male, right cervical lymph node enlargement, excision biopsy of the right cervical node. So this has some sclerosis here, but they are not forming banded sclerosis. There's effacement of architecture. There possibly is a vague nodularity to this, and you're seeing these large cells. They are multilobate cells, and the nucleoli are small. Again, here another multilobate. One has a nucleolus which is cherry red, and another smaller nucleolus. The background is a lymphocyte-rich background. Here again, multilobated cells here. Sometimes these cells can be difficult to spot. That can be a problem, and you might get confused. There's also a mitotic figure here. And the nodularity is appreciated better on immunohistochemistry, and you can see this CD21 highlighting these FDC meshworks that are sort of interconnecting in a way. And this is why it sort of has this interconnecting serpiginous areas. And here the holes, and you're seeing these large cells in these holes. Now this is CD30 negative. So you might say, actually, there are CD30 positive cells. Again, as I said before, look to see what is positive. So in this case, you can see what is positive are these large, what is negative are these large atypical, the culprits, whereas activated lymphocytes, which you can see in the background, are positive for CD30. And CD3 is forming the rosettes. And CD20 is highlighting in this part, you can see the interconnecting follicular structures, but if you go close, you can see that the large cells are also CD20 positive, as are the small lymphocytes within these nodular follicular structures. Here again, the same thing. And they are CD79A positive as well. They are OCT2 positive, which, as I said, is a very useful marker. And the small B cells are IgD positive because they're mantle zone type B cells. And you can see this here that the large cells are negative. And I want to say here that a subset of nodular lymphocyte predominant Hodgkin lymphoma, the large cells can be IgD positive. PD1 is, they're stuffed full with small PD1 positive cells, and they are the cells that form the rosettes. They are also positive for other T follicular helper cell markers. So this is ICOS and this is CXCL13. So don't think of a T cell lymphoma at this point. So this is nodular lymphocyte predominant Hodgkin lymphoma. This is fan pattern B. This is again a typical pattern, and this has a good outcome. Again, I want to emphasize that the ICC terminology for this is nodular lymphocyte predominant B cell lymphoma. And the last case is a 36-year-old male, lymphadenopathy query cause, and significant weight loss, massive splenomegaly, widespread lymphadenopathy query lymphoma. And it's a co-biopsy from a left cervical lymph node. Now this, unlike all the cases that we saw before, this is very pink. And the reason it's pink is because it is effaced by an infiltrate which also contains clusters of histiocytes. So it's rich in lymphocytes and histiocytes. And it's very easy now to miss the neoplastic cells here. But if you look hard, you find them. You can see these atypical cells. They're singly scattered large atypical cells with, this is a central nucleolus here. And this is also atypical, a little out of focus, but there are some atypical cells here as well. And these are histiocytes. So it's sometimes histiocytes have very small nucleoli. So more of the same, some large cells here. There are focal FDC meshworks on the CD21. CD30 is negative. Okay, so you can see these large cells here, and they are negative. The problem is with the histiocytes, sometimes it can be quite difficult to spot these cells. But they are very easily spotted on the immunohistochemistry. You can see they are positive for CD20, they are positive for CD79A. There are a few small B cells, but it's very difficult to spot them. FAX5 highlights these large cells, and there are some slightly smaller cells as well. OCT2 again spots these cells. IgD highlights very few, these mantle zone type small B cells. Okay, but they are there, but you can't see them very well. Now, CD3 is, there are lots of T cells, so that T cell rich, the terminology comes obviously because there are so many T cells here. So the lymphocytes are T cells mainly. The small lymphocytes are T cells. But you can see that they are PD1 positive, and the PD1 is forming layered rosettes around these cells. So this is PD1 positive, lots of PD1 positive cells. So then the diagnosis would be nodular lymphocyte predominant Hodgkin lymphoma. This is FAN pattern E, which is, we previously actually we used to call it as a descriptive term, T-cell histiocyte-rich large B-cell lymphoma, transformation of nodular lymphocyte predominant Hodgkin lymphoma. Because these patients, we don't call it transformed anymore. These cases have advanced stage disease and they don't respond that well to treatment, and they have their tendency to relapse. But if you look at these, this is the morphology here of T-cell and small lymphocyte and histiocyte-rich background, which are T cells. So these are T cell histiocyte-rich background, and you're seeing these large individually scattered cells. And here again, you're seeing these on the CD20. So the differential is, of course, there is a condition called T-cell histiocyte-rich large B-cell lymphoma, which is a vanishingly rare entity because most of the cases diagnosed as these turn out to be nodular lymphocyte predominant Hodgkin lymphoma, so much so that very recently I had a case which I signed out yesterday, where the patient in 2016 was diagnosed to have a T-cell histiocyte-rich large B-cell lymphoma based on a core biopsy like the one you saw, and the patient was thought to have. So this is a very aggressive disease, and these patients don't live very long, don't respond well to treatment. But this patient now, 9 years later, has thrown up another lymph node, which shows a typical nodular lymphocyte predominant Hodgkin lymphoma. So, but it may be impossible on a core biopsy. So you should give both differentials. The features that favor NLPHL is the abundance of PD1 positive T cells which form rosettes, the residual IgD positive mantle zone type B cells that you're seeing. So we've seen those, and partially preserved FTC mesh. So we've seen these three. So on WHO criteria, however, other areas of the biopsy must contain one or more of the patterns to be classified very confidently as NLPHL. And I think that is difficult in a core biopsy. But I think on what we have on balance, I can definitely favor nodular lymphocyte predominant Hodgkin lymphoma, FAN pattern E, which is a variant pattern. So again, I want to emphasize that the ICC terminology is nodular lymphocyte predominant B-cell lymphoma, which is actually in a way a more appropriate name for this condition. So in conclusion, remember that classic Hodgkin lymphoma and NLPHL, which is called nodular lymphocyte predominant B-cell lymphoma, also, so there are two names, unfortunately, in these two classifications. Remember, these two are completely different, separate disease entities. Remember that HRS-like cells alone are not sufficient to diagnose classic Hodgkin lymphoma, which requires appropriate inflammatory background. The differential diagnosis will depend on the subtype of classic Hodgkin lymphoma, and the classic Hodgkin lymphoma lymphocyte-rich subtype and NLPHL can be morphologically similar, and I would say indistinguishable on a core biopsy, and requires immunohistochemistry for the specific diagnosis. Immunoprofile of these two are very different, and in the NLPHL FAN pattern E has a T-cell histiocyte-rich background and can mimic a T-cell histiocyte-rich large B-cell lymphoma. And with this, I hope I have not given you information overload, and I'll take a few questions if there is time.
Thank you so much. I think that was a very, very comprehensive talk on Hodgkin's and its mimics. We have got some time, so we'll go through some of the questions that's been asked on the chat. The first one is based on your PowerPoint presentation in which they've asked the slide about angioimmunoblastic T-cell lymphoma. They were asking what is a big cell which is being encircled by the neoplastic T cells?
That is a B cell. So in just now I'm digressing a little bit, but in nodal T follicular helper cell lymphomas, the neoplastic T cells have an exaggerated T follicular helper cell function. So T follicular helper cells interact very closely with B cells, as you know. So there is a stimulation of B cells. So invariably in nodal T follicular helper cell lymphomas, there is a background increase in B cells. And these B cells can sometimes actually, they may also arise from the clonal hematopoiesis from which the T cell, nodal TFH lymphoma arose. And they can also give rise to either polyclonal proliferations or even clonal proliferations. And sometimes these cells have the appearance of Hodgkin-Reed-Sternberg-like cells. And they can also have a crippled immunoglobulin transcription profiles. They can be often EBV positive. So these can mimic classic, and I've seen so many cases which have been misdiagnosed, you see. So one has to be really careful. If you are careful, if you take the clinical and you look at the distribution of disease, firstly, don't underplay the clinical and then look at the morphology and look at the background. So the cells, that the large cells are Hodgkin, we refer to them as HRS-like cells, and they are rosetted by these neoplastic cells. So they will have the phenotype of the neoplastic cells, which will be strongly PD-1 positive. And if you're lucky, they will also express PD-1 and they look atypical, so you should be able to. But sometimes you see it happens, I mean, it can happen to me or anybody, anyone else, more senior pathologists. You look at the case and you think, oh my goodness, those large cells. And like rabbit in the headlights, your eyes go to those large cells and you kind of disregard what's going on in the background, you see.
Absolutely. So another question they've asked is, would we be expected to come to diagnosis for the cases hosted on, obviously we've only given an H&E. So the question is, would there be an expectation that
So if you get a nodular sclerosis Hodgkin, and you get a nodular sclerosis, not the syncytial pattern that I showed you, but if you see a nodular sclerosis Hodgkin and you get a typical appearance, I think, yes, you will be expected to give a definite diagnosis, but that you will do all these markers to confirm it. And hopefully you will be given sufficient clinical information to guide you as well. For instance, if you get a case of a 25-year-old with a neck node or a mediastinal mass and a neck node, which is, or you get even a mediastinal co-biopsy or even neck node biopsy, which is showing this. I mean, you don't get a nodal TFH lymphoma at that age. So you wouldn't say that, okay, the differential diagnosis in a 16-year-old is going to be, nodal TFH. You have to think carefully about what you're expected to give. Yeah. And then, of course, give your immuno and say what you know. So I think say as much as you can about what you know. If, on the other hand, you get a co-biopsy and it's a lymphocyte-rich background, then you can't tell the difference. And you have to be able to say, look, although you might favor something over another, depending on what you see, but you have to say that you will do immunohistochemistry. The differentials are these, and that's how you tell them apart. If you get something which is syncytial and sheet-like, you'll have to give the differential accordingly.
Yeah. So another question is, what type of background lymphocytes or other cells typically express BOB1, OCT2, and IgD?
Mantle zone type cells. So that's what you see. So that's the background B cells that you see in a nodular lymphocyte predominant Hodgkin lymphoma. Those follicles, the neoplastic cells are in the minority. They are individually scattered amidst small lymphocytes. The small lymphocytes, the rosettes are T cells, and we know they are TFH cells, so they're expressing. But the background is the mantle zone type. So it's a follicle. So normal follicles. Forget this. Normal follicles have a mantle zone and germinal centers. Yeah. So these are the mantle zone type cells. So they are reactive cells. So that's why they will be polytypic for light chains. Remember, I showed you that image of where the LP cells were kappa light chain restricted, but the background was polytypic for light chain. So they are reactive and they will be IgD positive. So those are those cells. Yeah, the mantle zone type cells. So although you have to see the neoplastic cells, you have to see the background rosettes, and you have to see the small B cells in the background. It's those small B cells that actually help you to differentiate, for instance, between a T cell histiocyte-rich large B cell lymphoma and, so those B cells in the background are quite useful sometimes in diagnosis as well. But in classic Hodgkin lymphoma lymphocyte-rich subtype, the background B cells will also be the same. So background B cells will be the same, but the T cells won't be the TFH cells. So they won't have this strong PD-1 positivity. Okay.
So someone's asked, can you explain the use of P53 and MUM1?
Yes. So the P53 and MUM1 are not specific. So MUM1 is, for instance, if a T cell is CD30 positive, it will express MUM1. If a B cells are CD30 positive, they will express MUM1. So that is not helpful. But if it is negative, it is helpful, because then I would think again about the diagnosis. So P53 is expressed and it helps you to highlight the cells. But again, it's not diagnostic, because you can see it in a variety of conditions. If it is not expressing, or if it's weak, very weak, then I would, because there is an accumulation of P53 in these cells. That's why.
Okay. Another question is, can follicular lymphoma be included in the differential diagnosis of NL-PHL?
Yeah. Actually, not really. It shouldn't be, but I have seen a couple of registrars, and that's the only reason why I brought it, because I showed you the difference between the two follicles. Really, it shouldn't enter into the differential. The only difficulty sometimes is if you have a progressively transformed germinal center, and that can confuse you. But what I was trying to say is that the follicles look very different. So the NL-PHL, you have these large cells in the background of mature reactive lymphoid cells, which are normal. Whereas in follicular lymphoma, what is in the follicle are centrocytes and centroblasts.
Okay. So there are a few questions asking whether we need the fan patterns for the exam.
No, maybe not. It's only if you want to score some extra points, you can say that. But actually, no, it was just for information, I think.
In Hodgkin's lymphoma, are only the large atypical cells the actual neoplastic cells?
In classic Hodgkin lymphoma, yes. The background is all reactive.
Yeah. Does PD1 show rosettes in classical Hodgkin's and a non-lymphocyte, NL-PHL?
NL-PHL, definitely the rosettes are PD1 positive. Okay, they're definitely PD1 positive, but they will positive, as I showed you, the PD1, ICOS, CXCL13. So they are all normally expressed in normal TFH cells. So just before the CD10 is expressed in only subset. So you don't get CD10 positive rosettes. So they will express the normal TFH markers that are expressed routinely in reactive TFH cells. In classic Hodgkin lymphoma, you can get some PD1 expression, but it's usually weak to moderate. You don't get the strength of PD1. I mean, I say this, we have had exceptions, but for you going for exam, they're not strongly PD1. The strength of the PD1 is what gives the specificity. PD1 can be positive, moderate to weakly in a lot of subsets of T cells. Okay.
Again, about PD1, does PD1 show rosettes in classical Hodgkin's and NL-PHL?
So that's what I've just answered.
Sorry.
Yeah.
So case 5, they said, why is it not THR-BL?
Why is it not? The reason is because I saw, the guidance, the help is that there was some FDC. There were a few small B cells, which you don't expect to have in T cell histiocyte-rich large B cell lymphoma. And all those T cells were PD1 positive, which gave them, that those are the features. And that's in my penultimate slide, I sort of showed you that and said that because of these, I favor. But as I said in a co-biopsy, you can't really tell it's okay. The exam, you say, I can't tell them apart. And I think that's better for you in the exam rather than coming down hard on one. We have the luxury of speaking to a clinician at an MDT and coming to a conclusion. The exam, you don't have that luxury. So you have to just say it could be this and it could be this. If you see features, you can say some of these features. You won't have all that. You'll get a case which is, you have to give the differential in this. It's very unusual for you to be given a case where, you're going to give these subtle features. I mean, that is for specialists really. So you have to, it's likely to be this, but it can be this also, because I can't tell them apart.
On a similar theme, someone's asked, could a differential for case 1 be DLBCL?
That's why I include primary mediastinal large B-cell lymphoma, but you see, they won't have this. So that can be enter into the differential. Yeah, can be.
Someone's asked to repeat the NL-PHL triad again.
The triad of the three things that you need, or
lymphocyte predominant, lymphoma, Hodgkin's lymphoma.
Morphologically, what you expect to see. So you have to
triad for that.
So the LP cells. Yeah. Then you have to see the background it's a follicular structure. So you see an FDC meshwork. Yeah. So that's important. And then, in the exam, you'll get an HNE. So you can't, you'll see the nodules, and that you have to, that is implied. And the background will be small lymphoid cells. You can see some histiocytes, and the small lymphoid cells are, the rosettes are the T cells, which are the TFH cells, and you see the background small B cells, which are also an important component. So small B cells, which are mantle zone type B cells, the T cells, which are TFH cells, which form the rosettes, and of course, the most important, VLP cell, which are OCT2 positive and B cell marker positive, CD30 negative, and negative for EBV. Yeah, positive for immunoglobulins, and yeah, okay.
Again, they've asked, do we follow WHO or ICC for the exam?
You can give both if you like. I mean, I have a vested interest because I mean, in the sense, not a vested interest, but I'm a co-author in the WHO, but I recognize the importance of the ICC terminology is, I think, quite a useful one. I'm not sure what your examiners will know. If you're very clever, you can put both if you have time.
Fantastic.
And just
I think
say
that
WHO in brackets. I mean, I think most, I'm not sure really. I mean, I'm sure the hematopathologist at the exam would know this. So it's all right, whatever you do.
I think either would be fine as long as you get it right.
So.
Yeah. So I think we'll draw this session to a close. Thank you so much for your time and for answering all those questions. We've got another one, but I think
I can take this very quickly. It's lunch, isn't it? So I can take it. Yeah.
A similar picture is in either diagnosis is EBV positive. Does it make a different entity? I don't know what do you mean by that. If a similar picture is in either diagnosis is EBV positive.
Positive classic Hodgkin, it can be EBV positive. So, and non-lymphocyte predominant Hodgkin lymphoma, for your intents and purposes, are negative. So that's a useful feature for you. And but there are other conditions that are EBV positive, as you know, EBV positive large B cell lymphoma, EBV positive mucocutaneous ulcer. So just because it's EBV positive doesn't tell you it's always classic Hodgkin lymphoma.
Perfect. So thank you so much. I think we'll draw this session to a close.
So thank you very much, everyone, for your attention. That was quite a rapid talk and included quite a lot of information. Now, these will be available as recordings on YouTube on the Diagnexia educational channel. And the reason I gave that talk, I shared that talk, is that I found it really helpful. It's a good mixture of the pitfalls that can occur in Hodgkin lymphoma, particularly between classical or nodular lymphocyte predominant Hodgkin or B-cell lymphoma. Also angioimmunoblastic T-cell lymphoma, infectious mononucleosis, T-cell histocyte rich, which, as Ayoma indicated, used to be a not uncommon diagnosis and now is incredibly rare, and people recognize most of it is nodular lymphocyte predominant Hodgkin. Are there any questions from everyone in the audience or not? Any points of clarification? Like I said, there's quite a lot of information in there, but it's going to be shared online, so you can always look at it and go through it again. I think it's actually a pretty good resource for this area. Yeah. Anything? No? In terms of antibodies, just to reiterate what Ayoma said, I know that antibodies can be, antibody availability can be low. I think CD3, CD20, CD15 and CD30 are really useful for Hodgkin lymphoma. The only other two that, if you were just going to choose one or two more, I would say the most important are CD21 and PAX5. So I find PAX5 really useful because classical Hodgkin lymphoma, the Hodgkin cells are always strongly positive for PAX5, and you get nice they're always weakly positive for PAX5, weakly positive, but you've got good, strong internal control, strong positivity in the B cells. So if you see strong positive, obviously you've got all the small lymphocytes, they'll be strongly positive for PAX5, the B cells. And then the large cells that you don't know what they are, if they're strongly positive, it's almost certainly going to be a nodular lymphocyte predominant Hodgkin lymphoma. And if they're weakly positive, and it's really clear distinction on the immuno, strong, small, round B cells, weak staining in the large Hodgkin cells, then that's really clearly a classical Hodgkin lymphoma. The distinction between nodular lymphocyte predominant Hodgkin lymphoma and T-cell histocyte rich large B-cell lymphoma, again, probably not relevant so much because the second one's pretty rare now. But if you do a CD21, if there are follicular dendritic cell networks, which is almost always in almost all cases, then it'll be a nodular lymphocyte predominant Hodgkin lymphoma. And if those networks are not present, then it's T cell histiocyte rich lymphoma. And that could be, and all that can be done on 4 biopsies as well. In terms of all the different patterns, A, B, fan type, etc., I don't think that's really relevant personally. And as Ayoma said, people wouldn't be marked down in it in the FRC PAP exam if they didn't state that. But the distinctions are classical, nodular lymphocyte predominant, and then the other mimics. So angioimmunoblastic, infectious mononucleosis, T cell histiocyte rich B cell lymphoma. Those are kind of like the main ones. Are there any other? So apart from that, is there anything from anyone?
I think people are kind of starting to drop off, to be honest.
Okay, that's fine.
Yeah.
So next week it'll be Dr. Perez Bayora.
Byers,
Talking on GI pathology. So I hope everyone can attend that, and then we'll be back to me doing hemopath the following week. We have speakers already planned apart from a short break in August, we have speakers already planned right away through to February next year. So spread the word, feel free to share the link, and look forward to seeing you all next week.